Welcome to the virtual Infectious Disease Congress, sponsored by Johns Hopkins University School of Medicine on ID Care Live. My name is Rachel Gottbaum, and you are tuned into a live CME session called New Trends, Concepts, and Diagnostics in Infectious Disease in 2012. This session kicks off our third annual Congress entitled Game Changers in Infectious Disease, a focus on important changes in the ID field. I would like to introduce the chair of this live online conference, Dr. John Bartlett. He's a professor of medicine at Johns Hopkins Medical School. In these 8 CME sessions over the course of the next 2 days, we will cover critical topics, including emerging infections, hepatitis C, and vaccine development. Faculty speakers include experts in the field, such as Drs. Paul Sachs, Calvin Cohen, and David Thomas, among others. Before we get started, I'd like to remind you that we will be taking your questions in real time throughout each presentation. You can send us your questions anytime during the program through the box in the lower left-hand side of your screen, and we will try to get to them. Dr. Bartlett, you're on.
Okay. Well, thank you, Rachel. So I'm going to be talking about game changers, and I'm going to actually divide it into two groups. I'm going to talk about the first group now, and talk about another collection of topics this afternoon. So the topics I'm going to talk about now are epidemics, resistance, diagnostics, influenza, and Clostridium difficile. And then I'm going to finish the menu this afternoon. So in terms of the epidemics, I'll just mention something that I think is important for us to recognize, particularly at a time when the CDC is being cut substantially with funding and so forth. So some great concern about how we're handling epidemics. And the ones I've got on the slide are the ones that I could think of that I think are worth mentioning. For example, the epidemic of influenza, not a lot of cases, but a total surprise in the summertime this year with an H3N2 strain. And then, of course, the hantavirus in Yosemite. The whooping cough, which has come back in roaring fashion, and now we know that that's due to waning immunity. So people that were vaccinated are no longer protected, and this includes the elderly especially. And accounts for the new recommendation of the CDC to vaccinate people over the age of 65, again, for whooping cough. And then, of course, the fiasco with fungal meningitis that I'll talk about a little bit more. This was the second biggest year in the history of West Nile virus in the United States. And of course we have this huge number of cases of hepatitis C, gonorrhea, anal cancer rates are way up, and we now categorize that as an infectious disease because of human papillomavirus, and salmonellosis. We always have salmonellosis, but 15 outbreaks, and some of them real big. So let me mention the fungal meningitis story. This started in Tennessee, and actually it's a heroic story at the beginning, because it was a single physician who had a patient that had Aspergillus meningitis, and taking the history found out that this patient had had spinal injection of a steroid a week earlier, and connected the dots and alerted the state health department. And then they spent all day and night chasing this down. The case report is, I think it's in this week's New England Journal. It may have been last week's. But it's a heroic effort by on-the-ground physician. At any rate, I think a lot of this is pretty well known. So it's the New England Compounding Center that was the source of all of this contaminated material. There were 3 lots that were implicated. They had already distributed 17,000 of them, and 14,000 people had already been injected. It caused a great deal of commotion. There's recently been congressional hearings. The FDA got hammered. The president of the company took the fifth. You know, so it goes on and on. I said 480 cases. I think it's up to 500 and some cases, with 37 deaths in 19 states. There's 43 lawsuits. There's obviously, and you dial into this and you'll get a lot of lawyers that want you badly. And they've frozen the assets of the people that own the company, which total $461 million. Those guys got rich.
Wow.
So here's where the cases were. A lot in Michigan, a lot in Tennessee. I mean, you can see the map. And I think what do we learn from this? Well, I think we learned a lot about the compounding process because most of us really didn't know what happened. So this is the New England Compounding Center, which is, of course, located in New England outside of Boston. And what they do is they take a chemical product, add liquid, in this case steroids, add a liquid, sterilize it. They don't put any preservative in, and then they distribute it around the world, around the country. And then the question is, well, who's in charge? Who is asleep at the wheel here? Well, the FDA does not have authority to really provide oversight of this state facility. The CDC investigates, it does not regulate. It's actually up to the State Board of Pharmacy, but you see what you have. You have a company in New England that's distributing in states all over the country. So you've got sort of somebody in Michigan that's being audited by Michigan State Board of Pharmacy that's actually distributing throughout the United States. So all of this has come to a great deal of attention, and I think what we're going to see is some sort of dual or tiered process of regulation in the future. We're a Pearl Harbor country, so it took this kind of an incident for us to respond. These are the cases that are being reported, and what you see on the slide is the early cases were all meningitis. And the ones that are showing up now are the spinal abscesses and osteomyelitis. So I just want to alert the audience that if somebody had one of these injections, and everybody that had one is supposed to know it, because that was the recommendation once this got started. That is, everybody that got one of these, and they could trace the lots, they knew who got them. And they should be warned. And the physician should be alerted as well. Okay, I'm going to go on to the next topic. The next topic is probably the biggest one in the field of infectious disease now, and that's resistance. I thought I'd start out with kind of a cute story. I'm not sure it's terribly clinically relevant. This is the cave, the Carlsbad Cavern cave that was found, discovered, never had life in it that we know of. It's 30 million years old, so it's been there a lot longer than people have been on Earth. And so they did the cultures of the bacteria, and they found a lot of resistant bacteria. And I guess the point of this is resistance was here long before antibiotics were here. They're kind of in the thin petita along the soil and water and every place we go. So it's perhaps not surprising that we continue to have a problem with antibiotic resistance because it was there long before we were. And here's what their curves look like. And across the top, what you see is the different antibiotics in those slanted lines at the bottom, and then the rates of resistance in the columns above. But they had resistance to every antibiotic, including the newest ones like daptomycin.
In this cave?
In this cave. In this cave. This 30-million-year-old cave. So more recently, we've had a lot of attention to Staph aureus, MRSA. Everybody on the street knows about MRSA. And one of the reasons is because of the St. Louis Rams epidemic, and of course that calls a lot of public attention to a bug and a problem. And this is the 5 players that were playing off each other that traded Staph aureus and bruises. And that was the epidemic. But what was really interesting in the New England Journal paper in 2005 was those columns of phage gel electrophoresis patterns that showed that these were epidemics that were occurring all over the United States in college football players and fencers in Denver, in college football players, in kids in Tennessee, and prison inmates in Mississippi. This was a big epidemic, and I think everybody that's listening to this probably knows about that. That epidemic came, and you know, it's kind of interesting. We saw a lot of devastating disease, necrotizing pneumonia, necrotizing fasciitis. We just don't see that anymore. Within
this MRSA.
With this bug.
Right.
And what I'm showing here is kind of the rate of bacteremia with MRSA in the Kaiser system. And you see it goes up, and now it's started to come down. There's thousands of cases.
And do you think this is a result of changes in the delivery of care?
No, I don't think we can take credit. I think these bugs kind of come and go. This one came out of all places, came out of Australia, pygmies that had not been treated with antibiotics. And it went around the world. Everybody has a different name for it. We call it the USA 300 strain. And this traversed the country. Everybody knew about it. We still have it. It's not to downplay. It's not to say it's not a bad bug. It's just not any longer increasing at the rate that it was. And it doesn't seem to display a unique pathology, which is what we thought it did at the beginning.
But weren't we taking more precautions as a result of this?
Well, we take a lot of precautions for Staph aureus in general and MRSA in general. So this is kind of in the mix. And the CDC now says about 30% of the hospital strains of MRSA are the USA 300 strains. That was not true 10 years ago. This is a new bug. But it seems to be pretty much like the old MRSA. Okay, now much more ominous now is the carbapenemase producing bacteria. And this sort of, what I'm trying to emphasize here is that resistance tends to be kind of a global phenomenon. That is, once the bacteria learn how to become resistant, they have the power to go around the world. This one started in India and Pakistan, where they have a lot of carbapenemase producing bacteria. And they traveled in 17 patients that went from India or Pakistan hospitals to London. And from there it went around the world. This was a really bad bug in the sense that it was resistant to virtually everything except a drug that most of us have very little experience with, colistin, a drug that we've had since 1961 but usually haven't used in years or even decades. This is a kind of a painful reminder of what that kind of a bug can do. This is not the same one. This is not the New Delhi strain, but this is a carbapenemase producing bacteria that started in New York, was transferred to the clinical center at the NIH. And when it got all, so this is a patient that had a carbapenemase producing Klebsiella strain, transferred knowing that, put on extensive precautions, what they call here enhanced precautions, and became the source of 18 cases and 6 deaths. So, and what I wanted to show here is what happened with this epidemic. So here is the epidemic curve. This is patient tracings. And if anybody watching this can make sense out of it, please let me know. I mean, that's just a traffic mess. And everybody that works in a hospital can relate with this. I mean, our patients go all over the place in terms of radiology and surgery and ICUs and different wards and so forth. The blue, by the way, on the left-hand side of the slide are the different wards, and the blue is the ICU. So, you know, like we've always thought, most of the worst bacteria are in the intensive care units. The slide on the part on the right is sort of their tracings of the patients as they went through the hospital. Now, nobody's going to be able to make sense out of that, but here's the Reader's Digest version. So here, number 1 at the top is the patient from New York. That's the source patient. Now, if you see the red line going off to the left, that's the second patient. Now, you'll see that there's another lineage that's going down straight, but the line between number 1 and number 4 is black, which means they were never in the same place at the same time.
So what happened?
I'm going to tell you.
Okay. Okay.
So here's the patient tracings. This is really detective. It was written up in a journal I don't read, but is one of those nature things that gets a lot of really good papers. What this is a patient tracing. It was called, by the way, The Detective Story by the editor. This is the detective story. So this is the, I don't know if you can see it better. I don't know if you can see it. I can't see it very well, but I know what the slide says. Right. Patient number 1 is at the bottom. Then patient number 4 is the third one up. Okay, you can see that the patient on the bottom and the patient on the third one up were never in the same place at the same time because the colors are different. However, the patient in the middle was in the ICU and for both of those patients. So that's where the overlap was. Wow. There was an intermediate that eventually became a case. But that was the detective story to find out what happened. Well, let me get to the bottom line. This has been the subject of review not only in scientific literature but in the Washington Post. What they eventually did to try to put out this fire was to build a wall around the patients who had it. They vaporized hydrogen peroxide in order to sterilize the air. They ripped out the plumbing at the NIH because Jack Bennett said it might be in the sink. They said, for heaven's sakes, we have water constantly flowing and hot boiling water at that. He said, you better look, and they looked, and that's where it was. And they ripped out the sinks. Then they did rectal swabs on every patient that came into the hospital. So I'm sort of, in order to figure out how to stop this. Well, they've stopped it. They haven't had a case in 9 months. But they wound up with, say, 16 cases and 6 deaths. So what I wanted to emphasize is sort of the enormous burden of work that's required for infection control when one of these bugs hits a hospital.
Is this also show the importance of data collecting, like you'll be discussing in your next section?
Yeah.
Okay.
So I didn't want to stop with the resistance story there, but except to say that it's pretty prevalent throughout the field of infectious disease. I've already talked about the top 2, but Neisseria gonorrhea has become a problem. Influenza, we've only got 1 drug left. I'll talk about it. Tuberculosis is a big problem. Malaria and cholera and the rest of the world. I mean, we're losing drugs left and right. And we're not getting any, we don't have much of a pipeline.
Why is that?
Well, because the drug companies don't want to make antibiotics anymore, and I'll tell you what the bottom line from a drug company executive is. Dr. Bartlett, if I make an antibiotic, you say don't take it. We give it for a short time. They're never very expensive. Cancer drugs are huge. You can pay $50,000 for chemotherapy. Most you can get out of an antibiotic in a hospital is $2,000. So it's the economics, and I'm not trying to talk about medical economics because I don't understand them, never have, but I do understand the reality of what it is. What they say essentially is this. Would you rather make a new antibiotic, or would you rather make a Lipitor equivalent that somebody takes for the rest of their life? So if you're trying to keep a company in business.
Right. So are you worried about that?
Yeah, oh yeah, we're scared to death. Yeah.
So you think that the governments will get involved eventually?
Well, I put some things here on this slide that sort of start to address that. I think one of the things that Rachel's asking me is, so what are we doing? Well, I think one of the things we have to accept is the fact that the United States is not doing very well. 80% of the antibiotics in the United States are given to pigs and cows. And that, don't forget, that's in the stool and the urine and the fertilizer and the runoff and the tap water. I mean, it's all over. And we're not sure. I mean, it's given for promotion of growth. Well, we're not sure. It really makes pigs grow bigger. So the reason to do it is not clear. They stopped it altogether in some of the European countries. In Denmark, they stopped it completely, and then monitored and said their agriculture industry was just fine, just great, and resistance went down. So MRSA bacteremia, this is a punishing or an embarrassing statistic. If somebody goes into to a hospital in the United States, they are 49 times more likely to get a MRSA bacteremia than if they went into a hospital in the Netherlands. Now, I didn't mean to pick the Netherlands necessarily, except that they have the data. Now, Sweden has the same data. Switzerland has the same data. Some of these other hospitals that really very, very aggressively address these problems do much better at it.
And when you say they are aggressive about addressing them, it's the fact that they collect data and you can follow the information.
Yeah. They have the data, and they do infection control, antibiotic control, and they can show, and I'll show you that in a minute. I think I'll show you in a minute. So here's a striking. This is to me just an amazing slide. Yeah. What I did was the European Union has something the United States doesn't have at all. It has tracking for antibiotic use for every country in Europe, 26 countries.
Amazing.
They've had it for 15 years. You can get it off their website, the European Union, the one that won the Nobel Prize this year. And they also have resistance data done in a systematic way by every country. So they're all marching to the same drum. So what I'm showing on this slide is the top and the bottom. The top is Greece, which has the most antibiotic use or abuse. And I've got it there as 38 daily drug doses per 1,000 inhabitants of the population. That's the metric they march to. And the Netherlands is at the bottom. Have almost 1/4 of that, or about 1/4 of that, 11. All right, now let's look at Klebsiella carbapenemase. In Greece, it's 38%. In the Netherlands, it's 0.2%. For Staph aureus, MRSA, it's I can't see.
It says 81.
81% versus 1.6%. I mean, we just got to do better.
But you were saying that in Greece, it's much easier to get antibiotics.
Oh, you can go in a drugstore and get Cipro.
Okay.
You can get anything.
Over the counter?
Over the counter. OTC.
Wow. Okay.
So I wanted to have a few things on here that we can do that might help this. And one is that it's not going to help the audience very well, except that it's something I have to think about. You know, if you Twitter, this is the kind of stuff you find. Finally over my cold, thank you, Z-Pack. 850,000 followers. That's pretty amazing. For that thing, yeah.
Wow.
Starting to feel better from flu, one antibiotic to go. I mean, we got to play in this ballpark. We got to learn how to do this.
So you show these social media slides, you show the Twitter slides. What are you showing us? Why are you showing us those slides?
Well, I think one of the things we should do is we should have a better way to communicate with the public. Europeans have done it better. They have an antibiotic day. They have an antibiotic. They have e-bug. E-bug. Every kid takes e-bug, which is a course on antibiotic resistance in school. They have e-bug. You can get it on the internet. Dial in e-bug. You get their course. Tells you what happens if you take an antibiotic. Oh, these guys are these people. European Union is much more serious. But in terms of what we can do, this is one of the things that I think is an important point for a consumer, and that is they love these probiotics. But, you know, if you take, it's not the bugs that belong in the colon that are in probiotics, because we can't grow them. But if you take one ciprofloxacin, it messes up the flora in a big way, and sometimes permanently. And I'm going to talk a little bit more about that if I get time to. How can you stop the abuse of antibiotics for viral infections, which I don't have to explain as a problem? When Cochrane Review did this, what they wound up saying is that the only thing they could find that would help was a delayed prescription. That is, somebody comes in and they say, I really have a bad sinusitis, and last time I got something, an antibiotic, and I wanted my antibiotic. What they said is, well, give them a prescription that's to be filled 2 or 3 days downstream, because most viral infections get better in that time. So they say, don't fill it if you're better. The patient walks away with a script, so they're happy. They're probably not going to ever take it, so we're happy. You and I, by you I mean listeners, are not going to be terribly happy with that. But that's the best Cochrane could do. You know what the French did? The French had a huge campaign about antibiotic abuse. They reduced scripts by 26%. And last year, the global antibiotics market reported France had the biggest decrease in antibiotics of any country in the world.
So are you saying to our audience that perhaps they should think about this delayed prescription strategy?
Yeah, I think that's something that we should suggest, since people often feel painted in a corner by patients who say, you know, every time I had this, I got an antibiotic and I got better, and the guy down the street will give it to me if you won't. You know, those kind of pressures and whatnot. But I try to fight them off. I've always tried to do that, but I must say that patients often are not very happy.
But if patients know about the risks of these antibiotics...
Well, that's what I was saying. I mean, maybe we have to communicate by Twitter, or maybe we have to communicate better in the office, but some way we got to do something differently. This is a short course. Short course is another way to reduce the total burden of antibiotics, and this is a comparison of a number of controlled trials showing that short course always wins. There was one exception. I actually truncated this. It was 32 studies of short course versus long course. And if you look at the short course, they're actually pretty darn short, like half for 3 days or 5 days, half for 7 days instead of 10 to 15 days, pyelonephritis for 7 days. And I guess the one exception to point out was urinary tract infections. A single dose was not adequate in pregnant women. That was the only time I could find where a short dose or short course was inferior. Another way to do this is with procalcitonin. People in the United States don't use it very much. They use it a lot in Europe. And that facilitates decisions about when to start or not start antibiotics, or when to stop antibiotics. It's been used a lot in Europe, as I mentioned. And this is a review, again, by a Cochrane group, 7 controlled trials, 1,400 patients, by using the procalcitonin to tell them when to start or stop antibiotics. They reduced antibiotic use by 51% with no downside, no harm.
And how does it work? This is a test, or this is a...
This is a test. We don't know why procalcitonin is there. We don't know why God gave it to us, but we do know that it marks bacterial growth.
And so should our doctors be using this test when they're prescribing antibiotics?
Yes. I think what they should do is when they have, if you see a patient with community-acquired pneumonia, you're going to give an antibiotic. Is procalcitonin going to help you with the decision to use an antibiotic? Probably not. Not if there's a consolidated infiltrate. They're all going to know that. What it may help you do is if they have an exacerbation of chronic bronchitis, and they're in one of those groups where, maybe it's a bacterial infection, maybe it isn't, this might help. Or in the community-acquired pneumonia, it might say, I can stop your antibiotic. Procalcitonin is down to normal. And a lot of us have traditionally used C-reactive protein or sed rates or those things. They're not anywhere near as good as procalcitonin for this purpose. Okay, here we go. Oh, this is not for us. So this is I guess I slipped by, I'm sorry. This is a review that I really liked on the topic of procalcitonin, but I got to move on. It was for respiratory tract infections, but the guy went back and 4,000 patients got the individual records and filled out these big long forms on 4,000 patients to find out about the use of procalcitonin in controlled trials. And what he showed is the red line is for the number that got antibiotics, and the blue is for the number that got procalcitonin-driven antibiotic decisions, and the blue is the one that didn't. These are the controlled trials. And a reason I wanted to show it is when I talked to the author about this, what he said is the best use of procalcitonin is when you have a low probability infection and you need to know whether to start antibiotics or not start. That may push you over the line. Or if there's a high probability of infection, you're going to give an antibiotic like the example I gave, but this may help you know when to stop.
So this really needs to be part of the repertoire of these doctors to stop all these problems associated with antibiotic use.
Yeah.
I mean, that we need to use this as a tool now.
Yeah. So here's the antibiotic pipeline, and it's not very rich right now, but you'll notice that down at the bottom is Hail Mary, and these are the drugs that were approved back in 1959 to 1961. Colistin, IV phosphonomycin, and fusidic acid. Colistin, I think, is getting a record amount of use now because we have to dust it off and use it. Phosphonomycin IV looks pretty good in Europe, at least so far. Colistin, I wanted to mention a couple of things about it because I wanted to point out that the time it was approved, the FDA methods were a lot different and whatnot. What's on the package insert is not smart. So it will say the maximum dose is 350 milligrams a day, and it's actually more. This is a very thorough review of the topic by the king of the mountain for Colistin. The recommended peak, or the recommended maximum dose, is 475 milligrams per day. And you always combine it with something else. Now, something else is quite variable. It's rifampin, meropenem, minocycline, the carbapenems. And the reason for that is a phenomenon called heteroresistance. But you got to mix it with something else. You can't use it alone, or you can't depend on it alone. Now, I want to say something about microbiology. Microbiology is, of course, embedded in what we did in 1850. That's culture on seaweed. Then we've got the point-of-care tests that can be done rapidly in the emergency room or in the office. I did want to emphasize the CLIA-waived part of this. CLIA-waived means the FDA says that you don't need a laboratory technician. You just need somebody that will be on the license of the laboratory, of your hospital laboratory. For example, I can do this for a number of different rapid tests. And the nice thing about that is if you don't have to send it, if you have to send it to the lab, usually you have to wait a long time, and they're gone. They're not in the office, or not in the emergency room. Right. They're gone. So you write the script without this information. The nice thing about the rapid tests, if they're CLIA-waived, is that you get the information right away. So why you can do it right now?
So why aren't we using it more?
Well, we do use it. Well, the problem is the FDA is very, I don't know, timid about letting us do it for some tests. And molecular tests are the wave of the future. So one of those is the rapid test for detection, and you can see the number of bacteria. This is just going to increase and you can see the number of suppliers as well. So huge market out there, big uptake, should be. Film array is one of the latest. Look at this. They can detect about 20 respiratory tract viruses. They just got approved for Legionella, Mycoplasma, Chlamydia pneumoniae, and Bordetella pertussis. Now I put strep pneumoniae in parentheses because it was not FDA approved for that. But you can imagine how helpful this is going to be as a rapid test that where the results would be back in an hour. And this but don't forget, this is not CLIA-waived.
But this is coming down the line now?
It's here.
And so is it expensive? Is it going to, do we have it?
Well, I think the laboratory technicians would think it was expensive. I can't tell you the price, probably $25 or $30.
Well, that's...
but, I mean, look at the information you get.
So this is the new wave now. So we have this.
This is, you got it. This is the new wave.
All right.
This is going to be molecular diagnostics.
Right.
But there's one part of this that I did want to mention. You got to be careful, because all of the ones above the pneumococcus are bacteria or viruses that should not be there. And therefore, their presence detected by a molecular test mean they cause disease. But the pneumococcus is in about 30 or 40% of adults. So to have it doesn't mean it's causing disease. And therefore, you're going to have to do it semi-quantitatively. This is going to be semi-quantitative. So that tells you the number. So if they're in a large number of, a lot of numbers, then you might say, well, this is the pathogen.
Okay.
This is what I think the kind of the future of diagnostics. It's a kiosk that's in our emergency room, and you say, "What do you want to know if you have a sexually transmitted disease or HIV?" But this could be influenza, it could be any one of a number of things. And the patient's given the opportunity to say, "Yes, I want to know," and "Yeah, I want to do the test myself." And when they do it, they are right 100% of the time. 100% of the time. What you have to do is be able to read a red line. I think that we expect that this will go much further in terms of availability, like you know, the pharmacist that now gives injection of influenza vaccine
That's
and
right.
so forth.
The minute clinics.
And
right,
yeah,
right.
and soon will be, and also now giving a variety of other vaccines. I think we'll be able to make diagnoses in drugstores. Whether this is a good idea or not, I'm not saying, but I think this is the wave of the future. Now, that's what I showed you is the Chevrolet version. This is the Cadillac version. This is the big gorilla. This is the Plex ID, which is able to identify 4,500 different microbes. And this is coming, and this will be a godsend. This will revolutionize microbiology. This is in our lab, and it shows influenza at the beginning of the season at last year, and this is what it looked like at the end of the year. I mean, that thing had changed 1,000 times. And this was actually the machine that discovered the 2009 pandemic flu. I mean, it was done in a kid in San Diego, and the machine said, "I've never seen this strain before. It's brand new." So you can see now what an incredible public health thing this is. And I've sort of said this here. I mean, can you imagine having this? If any of you lived when Legionella was such a mystery.
That's right.
Oh,
right.
so awful. And we couldn't find out what caused it, and HIV and SARS. And then influenza of 2009 and epidemics.
So what will this tool allow us to do with new influenza viruses, say?
So for new influenza, what it will do is it will say this is a new strain, and this is then therefore potentially an epidemic strain, and we got to know about this because it may not be in the vaccine.
And didn't we have that information before we had this machine?
Oh, we could have it, but you'd have to get the strains. You would have to then send them to some, the one that they got in 2009, nobody thought that was any different. I mean, it just turned out to be influenza.
And this technology will tell us right away?
Yes.
Wow, that's powerful.
So what's new with flu? I don't have much time left. So
we have about 10 minutes. We have a few minutes for questions.
Okay. This is the influenza vaccines, and of course there's a bunch of them out there. I just mentioned, I might emphasize the one at the bottom. It's a brand new one. It's made by cell culture. It's been approved by the FDA. When it was presented, it showed efficacy of 83%, and it's going to be made in the United States. So this is the product of a big national effort to get a new influenza vaccine produced by cell culture, which means you don't have to wait 9 months. I mean, this comes fast. You don't have to grow it in eggs. This comes fast because it's cell culture. And it's approved for people over the age of 18 years. I don't know what it costs. I don't know that it's better than the stuff above the list. I just know that the technology is advancing, and that's exciting. Now, one thing I'm going to go past this. One of the things I think we should emphasize is that most of us have sort of grown up to say oseltamivir, the anti-flu drug, the only one that's left standing, was zanamivir, but it's hard to deliver. Oseltamivir, Tamiflu, we have a 48-hour window, and we've all been told that. The CDC is recommending that if anybody has influenza and they are sick enough to be in the hospital, or if they're at high risk, like chronic lung disease or chronic heart disease or chronic renal disease or neurologic deficit, I mean, a very broad panoply of chronic diseases, then they should be treated with oseltamivir regardless of how long the flu's been going on. It's better if it's early, but if you can't get it there earlier, then you give it when you can. So that's a major change, perhaps, for many of us. Can we show that it works? Here's a study that did seem anecdotal, not controlled, but it did seem to show by those bars that are above the long line that out to 5 days there was a better outcome in terms of survival with patients that got oseltamivir with influenza. This is just to remind us that that bug can become resistant to oseltamivir almost overnight.
Wow. So what?
So look at that line. Now, back when we had the other strain that became resistant, that was in 2007, that was salvaged by the neuraminidase inhibitors. We don't have those anymore.
So what?
We don't have anything left.
What, right, it's not a good prospect.
That's the point.
Okay, I got that. Okay, great.
Clostridium difficile, I'm going to just mention a couple of things because I don't have much time left and I'm getting signs put up in front of me. Okay,
well, we want to make room for some questions. We've got lots of people want to know stuff.
So, Clostridium difficile. Your laboratory probably uses EIA or PCR. EIA is specific but not sensitive. So you get a lot of false negatives. PCR has a lot of false positives. It is a molecular test that can detect one crummy C. diff in a stool. So in our state, for example, when labs went from EIA to PCR to detect C. diff, their rate of C. diff went up they doubled. By 100%. So, I mean, I just want you to be aware of that. If you've got a positive test, the first question to ask is what test was positive? And if it's an EIA, then it's probably right. If it was negative and it was an EIA, it may still be C. diff.
So then why are we using that?
Well, we're using it because first of all, it's cheap. It's been around since 1984.
Right.
A lot of laboratories are hooked into it, have been using it for a long time. It doesn't have the problem of false positives.
Right, but if people are going to be running around with C. difficile,
well, it depends on the art of medicine. If you're looking at a patient, you say, I'm pretty sure this guy's got C. diff, despite the fact the test is negative, either send it for a PCR or just treat him for C. diff. Now, there's an epidemic, as you all know. Here's the picture in U.S. News and World Report for front page story. Went from 100,000 cases or 67,000 cases to 350,000 cases. Big epidemic. Thought to be due to this NAP1 strain. I'm not sure this is true. I think the NAP1 strain was an epidemic. I'm not sure that it is more virulent, and now we're learning that it probably isn't. This is one of the studies that addressed the issue of the NAP1 strain and showed that it responds a little bit less than the other strains. I show it because it's a really good study. It was comparative, it was blinded and controlled. But here's what I really wanted to get to. I see a lot of patients with relapsing Clostridium difficile. So here's the algorithm. So you got a 50-year-old patient that gets dental stuff and then gets C. diff. Because of clindamycin. And you have to decision about vancomycin or metronidazole. Metronidazole does not get in the colon very well. Why it works, most of us can't figure it out. But it seems to work. It's been hard to show that vancomycin, which make absolute sense, goes right to the colon. It's never been resistant, never been a resistant strain. We don't know why it isn't a lot better than metronidazole. It turns out it's a little bit better. And you can see that on this slide for severe cases. And this is a meta-analysis that shows a little bit better for vancomycin versus, in terms of failure, 14% versus 22%. Relapse rate is about the same. Now let's finish the cascade. Now the patient has a relapse, number 1. You give them the same thing according to the guideline. Relapse number 2. You have the option of giving either fidaxomicin, vancomycin plus rifaximin chaser, vancomycin taper and pulse, or a stool transplant. 4 ways to deal with the second relapse. First relapse, you treat the same as the first. Fidaxomicin's the new kid on the block. It was no better than vancomycin in terms of cure rates, but it was better in terms of relapse. These are the data supporting the taper and pulse. The taper is 1 pill once a day. You give them the regular dose, and then you give them 1 pill twice a day for 1 week, then 1 pill once a day for 1 week, and then 1 pill every other day for 6 weeks. And this is a study that's intended to show, that's the one at the far right, that showed they had the best outcome. Now, I mentioned that fidaxomicin is an option for this patient that has multiple relapses. I showed you the 15 versus 25%, and this shows 36 versus 20%. So fidaxomicin is better in terms of preventing a relapse, and this is what the curve looked like. And then this is a retrospective review of the rifaximin chaser, as it's called. And I'm not going to have time to explain it. The stool transplant is the miracle. This is a procedure where you take stool from a normal person and put it into a patient that has multiple relapses, and they will have normal bowel habits from them on. And the record is 90% have a cure. And you can put it in from above, you can put it in by an enema, or you can put it in by colonoscopy, and all of these are successful.
Okay.
And I'll just mention one other thing. England had a huge problem with C. diff, big outbreak, an order from the National Health Service, bring it down, and they got it down by 60%. How did they do it? By antibiotic control. Fluoroquinolones and broad-spectrum cephalosporins. And they got it down by 60%. Antibiotic control, mostly fluoroquinolone driven.
Wow. So that's really the take-home message here, isn't it? I mean,
well, I think it is for C. diff, yes.
And I mean, this antibiotic use. But I want to thank you. We didn't get to our questions, but people will have plenty of time in your session at 3 o'clock and at other sessions. And don't forget to fill out the quiz at the end of this to get your CME credit. Thank you very much. I'm Rachel Gottbaum, and this is ID Care Live.